Oh, there we go. All right. Jiminy Christmas. Okay. Yay. All right. So do I have sound? Looks like I have sound. All right. We are ready to go. All right. Happy Monday. How is everybody today?
Almost it. Today is the last Monday.
Today is the last Monday.
Oh.
This is graduation week. So yeah, it went fast, didn't it? Does go fast. All right, I'm going to get your scores for chapters 8 and 9. So I know you got your test date. Anybody else get your test dates? No? Anybody else register yet? Okay.
Is there a certain deadline by which we have to register?
No, because you're registering as a challenger. So there's no date. But I will caution you on this, guys. I know that right now you probably feel like you aren't ready to test. Okay, and I get that. I do understand that. But you're never going to be more ready to test than you are right now. And that's the reality of it. If you wait, and I've seen it 100 times, guys. If you wait, I'm not going to register yet. I need to practice a little bit more, right? Well, time passes and you don't practice. And then you're like, okay, well, now I really need to practice because it's been 2 months since my class and I'm not remembering a whole lot. And you start to practice, but now you get a little unsure of yourself because it's been so long, and time passes and time passes and time passes. And then you're a year out and you're like, I can't register now because I'm not going to pass. You're never going to be any more ready than you are right now. Okay. Does that make sense? And believe it or not, you know this. So let me give you, I want to talk about this. So I went to a conference. It's called HOSA, Health Occupation Students of America. I go every year. I am their celebrity guest. It is so much fun for me because students and instructors come and take pictures with me because they've watched me on TV all year long. And a lot of them have gotten ready or getting ready to test. A lot of them had already tested and they passed and they were super excited. But at this conference, I actually judged an event for home health aid, and I judged denture care. That's what we were judging. Now, guys, I teach this for a living, right? And I'll never judge skills again, by the way, because a couple of them, when they came in, they saw me and recognized me, and that just raised their anxiety level. So I won't ever judge skills again. I learned something from this. I don't want to make anybody more nervous than they already are. But what amazed me, so can you guys tell me some things that you have to do for denture care? Do you guys remember denture care? We went over it. What are some things?
Cold water.
Okay, cold water.
Washcloth in the sink.
Washcloth in the sink.
The denture brush. Okay,
denture brush. Yeah. Basin. All right. Toothpaste.
A cup of water.
A cup. Okay. All right. Okay. All right. So you guys could manage to put this together, right? I didn't hear a single one of you say read the care plan. Every skill starts with the care plan. That's always step one, guys. If I ask you to do denture care, what's your first question going to be? Yeah, where's the care plan? I need the care plan. Because that care plan is going to tell you how to do denture care, which you guys just told me how to do on this patient, right? So care plan is key. And that is what happened to a lot of these students. They did not read the care plan. They just went in and tried to do denture care the way that they had done, but that's not what the care plan said. The care plan was specific in that you didn't do mouth care on the patient. You just gave them mouthwash to rinse their mouth out. But if you didn't read the care plan, you wouldn't know that, right? Does that make sense? So it was a great reminder for me. And this is what I'm bringing back to you. So I'm glad I judged, because it actually got me to see things from the student point of view again. And it's been a little while for me. So it was a good experience for me to come back and remind you of the things that you're going to forget when you're testing. Does that make sense? Okay. So when we think about denture care, we're thinking about the steps of denture care. Washcloth in the sink, cool water. These are all the things I heard you say, right? Denture brush, wet it first, toothpaste, put the dentures in the cup of water. We're thinking about all of those things. And that's appropriate, right? That's all part of the skill, but there's so much more to the skill, like the opening, using a barrier, wearing gloves. We actually had 2 people that did denture care without gloves. We have to think about linen rules. No linens go on the floor. We had a person that put the linens on the floor. You know, when she was done, she just put them in a pile on the floor. So we have to remember these principles, because they're going to tell us how to do the steps that we need to do. So it's not just cool water, washcloth, denture brush, toothpaste, put them in a cup of water when you're done. That's all part of it, but that's just part of it. Most of our checkpoints are coming in the opening and the closing. Does that make sense? Mm-hmm. So don't get so tunneled in. Don't get so focused in on the skill itself that you forget the other principles that make up the skill. Good. So this was a good learning experience for me. But remember, and I've said it, every single skill, how do we know what to do with this patient? The care plan, right? So every skill, your very first thought is care plan. What does a care plan say for this? Yeah, I know how to do denture care, but I don't know how to do it on this patient. Does that make sense? Don't forget that. Now, when I first made this program, when I first made those testing care plan sets, I was really worried about this, and it has happened, and I'm not real happy about it, but we're too far into it now. I was really worried about this because I'm giving you the actual care plans from the exam, right? At the top of every skills page is the actual testing care plan. So you guys are watching me do it. You're reading it in the book, and it's all the same way because that's for this one patient, the testing patient. But we have to remember that's one patient out of 8 billion. We're about, yeah, we just hit 8 billion on the planet, by the way. So that's one patient out of 8 billion. Remember that. That care plan only works for that one patient. You have to look at the care plan for every single patient to find out what we're doing for that one. Is that good? But I was really afraid of that. And I'm starting to see that a little bit in that we tend to want to generalize, okay, all denture care is done this way. No. It's not all done this way. You know the basics, right? You know how to do denture care that way, and you'll adapt it based on the care plan. But remember that adaptation has to happen because every patient is different. So those are the lessons I learned from most of this year. But you will never be more ready than you are right now. Keep that in mind.
When we do the care plan, when we're doing our test, does it give us the supplies that we need?
That's a great question. And the answer is no, you have to learn the supplies. Yes, I know. I know everybody's like, what? Yeah, no, I get it. But no, and the reason is this, okay? If we're working at a facility and I'm the nurse and I ask you to go in and give Mrs. Jones a partial bed bath, and I tell you face to waist, front and back, it's what I need you to do. I'm not also going to tell you, okay, and you're going to need to take with you a basin, soap, lotion, 4 washcloths, 2 towels, a hospital. You know, I'm not going to do all that. I'm just going to tell you, go give a partial bed bath, face to waist, front and back. I expect you to know what you need to accomplish that task. So yeah, you have to learn the supplies because in a clinical setting, nobody's going to tell you what you need.
So if you forget any of the.
Okay, so that's the real question, right? So what happens during the test if I don't get the right supplies? There is no checkpoint anywhere that says got the right supplies. Nobody's grading you on it. What they're grading you on is what you do or don't do with supplies.
So if I forget 2 boxes, I can go get 2 more.
You can at any time during the test because you have to have those washcloths to complete your task,
Okay.
right? But it's like everything else. Hold on. It's not the whole story. Hold on. You can go get whatever you need whenever you need it. No worries. But once you have touched that patient, are your hands clean? No. And you've got to reach into the clean supply shelf or the drawer. Can you do that with unclean hands? Because one of our rules is we only touch supplies with clean hands. Remember that rule? That's this scenario is what that rule is all about. So if you forget supplies, not a big deal. You can go get the supplies that you need when you realize that you need them, but you have to remove your gloves and wash your hands before you get supplies because our rule is you have to have clean hands to get your supplies. Does that make sense? Good. So yeah, you can get whatever you need whenever you need it. There's no checkpoint that has to do with supplies. All the checkpoints are about what you're doing with the supplies. Okay. Good. Any other questions? That was a good question. Okay. I gotta turn my phone off. Hold on a second. Okay. So our scores for chapters 8 and 9, this is on page 140 and 141.
39 and 140.
Oh, is it? Oh, I'm sorry. Sorry about that. 139 and 140. You're absolutely right, Amy. All right. Bryn, how did you do?
Chapter 8, I got 2 wrong. And then chapter 9, I got 1.
Thank you. Nadia?
Chapter 8, I got 2.
Thank you. Lauren? I'm sorry, 0. Okay. Very good. Irasima?
2 and 8 and 1 and 9.
Okay, thank you. Joanna?
I got 2, and chapter 9, I got 6.
Thank you. Rosina?
Chapter 7, I missed 3. Chapter 8, I missed 1. And chapter 9, I missed 0.
Very good. Damwanti? Thank you. Mariah? Caitlin?
On chapter 8, I missed 4, and on chapter 9, I missed 0.
Thank you. Do you have 7 for me as well?
Yep, I missed 1.
Thank you. Joni?
Chapter 8, I got 2. Chapter 9, I got 1.
Thank you. Gabrielle? No worries. Erica? Amy?
218-9.
Very good. You guys have any questions about anything that that you had on that? Anything you missed? Anything you want me to explain to you?
I can't find it. There was one, thing that said, I don't know if this is it, walk slightly in chapter 9. I'm not sure if this is it. It was something, what threw me is it was the first time I had read, place something on the weaker side.
Okay. So I think you're talking about like canes and things like that, right?
I guess I just don't, I thought I had marked it, but I can't find it. It probably was,
Okay.
yeah. Let me see, that's chapter,
It probably was chapter
that's here it was.
probably chapter 9.
I should have marked it, but I can't find it. But it was something, that was the first time I had read something about placing something on the weaker side.
Yeah, and you may have a hold on one second. I'm just getting Erica's scores here. Erica, do you have chapter 7 for me as well? If you do, please put it in the chat. And wins, congratulations on passing your exam. We're super proud of you. So, all right. So when we're talking about utilizing canes and walkers and all of those types of equipment, physical therapy is going to be the one that implements that. Okay, that's not really something that CNAs do. Physical therapists figure out what adaptive equipment is needed and they provide it and teach the patient how to use it. You're going to follow their lead. Okay, we're not, that's not our role. As CNAs, we don't teach patients anything. So you kind of have to keep that in mind. But it is helpful to know when it comes to adaptive equipment, what the norms are. Now, just because that's the norm doesn't mean that that's going to happen in every single instance. Does that make sense? Okay. But yes, there is a convention where that tells us in general how to use a cane, where to put the wheelchair, that type of thing. When it comes to the wheelchair, particularly because that is something that we have to know, because your physical therapy isn't going to be telling the patients how to transfer from bed to wheelchair. So when it comes to a wheelchair, you always want to pivot on the stronger leg. Okay. So we wouldn't want the weaker leg to be the one that we're pivoting on. So when you're looking at the bed, where the patient is, and the patient is sitting on the side of the bed, you got to figure out if they have a weaker side, which side is weaker, and we want to pivot to the stronger side. Does that make sense? Okay, so that's the one that you really do need to know, because that's not something that physical therapy is going to teach a patient. Okay. Good. Good question. All right. Oh, thank you, Erica. I appreciate that. Okay. All right. Today we have 3 skills to do. You're going to have a lot of practice time today. These 3 skills are, well, catheter care is a little bit longer, but range of motion and drainage bag are both very short skills. Not a whole lot that I have to tell you on each one. So today's going to be pretty quick as far as skills. Should have about 2 hours of practice today, roughly. Okay. All right, so let's go to page 57 and we're going to get started. 57. While we're getting ready for this, A question I get asked a lot in this program, especially when we get to this point, is do I have to say everything you say when I'm doing these skills? Right? Because I say a lot. And the answer to that is, well, you should. It doesn't have to be exactly what I say. Like, you don't have to memorize the script, but you should be talking to your patient and you should be telling them what you're doing. And I have to go back to the very first day when we talked about the patient experience. Remember that you are a stranger and you're in a place full of strangers to the patient. They don't know anybody. Do you think they might be a little fearful? They aren't CNAs. They aren't. So how can we expect them to know what we are doing with their body if they didn't sit in a class like this? Right? So when we're doing skills, it really is kind of important that we're telling them the steps that we're doing. It will also help you on the test. And that's because, remember, for the test, the evaluators are going to be looking at that checklist. If they're looking here, they may miss seeing you do something. So if you're saying things out loud as well as doing them, the evaluators have an easier time checking you off and making sure that you got all of the steps in. Does that make sense? But there's another benefit to talking out your skills. And that's, it does remind you of what the steps are. If you're completely silent when you're doing these skills, your mind will wander. It just will. You'll have a hard time staying on task. And that's when you start to get really nervous and you realize the evaluators are watching and all of those things that can derail you. So if you're paying attention to the patient and you are talking your steps out to the patient and making sure they understand what you're doing, it'll remind you what the next steps are. It keeps your mind sharp and focused and helps keep you on track. The people that talk out the skills do much better on the state exam than those that are silent. But from a patient perspective, it's just way better. Way better. Because now they feel like a partner, not a prisoner. Good? Makes sense? Yeah. Prisoners, we don't have to tell them what we're doing to them. We can just, handcuff them, lead them around, make them go places. But we really shouldn't be doing that to people that aren't prisoners. I don't even think we should be doing that to prisoners. I think that every person has a right to know what's happening to their body. All right, so page 57, our care plan at the top of the page tells us to provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion, extension. Do you guys remember what flexion extension was? Up, down. So when we do this skill, this is actually going to be a 2-for-1. We'll get to the rest of the care plan in a minute, but this is a 2-for-1. So when we have a leg here, let me stand over here so you guys can see a little better. When we have a leg, if we bend the knee up toward the chest, kind of like they're walking up steps, do you see how that bends the knee and the hip at the same time? So this one exercise gets both joints. So we're going to bend flexion extension. It tells us the hip, knee, and ankle. So we're going to do the hip and knee together. Now, this is kind of important, though, because if you just raise a leg off of the bed, so for instance, if I just try to do a straight leg raise with this patient to get the hip, this can be very painful for patients with sciatica. Okay, a straight leg raise, it pulls that nerve that runs from the lower back down the leg, it pulls it super tight. And when you have a patient with sciatica, that can be very, very painful. So we don't do the hip independently. It's always part of, we bend the knee as well, because that by bending that knee, keeps that nerve a little bit more relaxed. Does that make sense? Okay. So we're going to work on the hip and the knee together. And then we're going to work on the ankle by lifting the leg off the bed, because we don't want that heel to scrape against the sheets. So we're going to lift that ankle off the bed just a little bit and bend the foot forward and back. Our care plan goes on to say to provide 3 repetitions of each exercise. So knee to the chest and back to the bed 3 times. Lift the leg, foot forward and back 3 times. Put an opening in front of it. Put a closing behind it. And we've got ourselves a skill.
Since the hip and knee are the same, it's only just the 3 times for sort of like the combo. You don't have to do it 6 times.
Nope.
Okay.
3 times for the combo. Yeah. Good. Questions? Says the resident's not able to help with the exercises, so we're going to do this. Okay. All right. So I need batteries. And I was in such a hurry on Wednesday, I forgot to, or Thursday, yeah, Wednesday, I forgot to do everything I needed to do here. All right, I need a volunteer, somebody to go lay down in the middle of the bed over there. And I will show you the skill.
Do I need to take my shoes off?
No, it's fine. Okay. Turn on the air. I'm getting a little warm. I know you guys are comfortable, but I'm a little warm. Okay, I'm going to do this skill and simulate hand washing for the sake of time. So we're going to pretend this is my second skill. Okay, remember that we have to pay attention to which body part we're exercising. If I get ready to start the skill and I can't remember whether it's the right leg or the left leg, should I guess?
Look at the care plan.
Yeah, I should go back and look at that care plan. Now, the care plan is telling me to do the right hip, knee, and ankle. I know that. But if I'm not 100% sure, I shouldn't guess. Okay. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some exercises on your right leg. Is that okay? All right, I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I have clean hands. All right, Ms. Jones, I'm going to lift your leg and I'm going to bend your knee to your chest and back down to the bed. We're going to do this 3 times. I'll do all the work. You just let me know if there's any pain or discomfort, okay? So do I ever grab above?
No.
Okay. So I'm going to under the knee and under the heel. We're going to bend up and all the way back to the bed. Feel okay? One more. Up, all the way back to the bed. Still good? One more. Up, all the way back to the bed. Good? All right, so now I'm going to lift your leg up and bend your foot forward and back like you're stepping on a gas pedal. You should feel a little stretch, but if there's any pain, let me know. So foot off the bed. We're going to bend forward and back. Good. Forward. You feel it stretch? There's 3. Good. Any pain? No. Okay. Is there anything I can get for you before I go? Are you comfortable? Would you like a magazine? Okay. Let me get your call light for you. My environment is clean. So here's your call light. If you need anything at all, let me know. Wash my hands. Think about the steps of my skill. I would probably read the care plan one more time just to make sure. Tell the evaluator my skill is done. Thank you. So if I got to pick my skill, you know, if I was able to say, okay, I want this skill for the exam, one of the range of motions would definitely be on my list, right? Probably respirations, because that's quick and easy. They're just
Pulse.
pulse. Pulse, you have to count with 2 evaluators though, so it's a little bit longer. But yeah, it's still an easy one, right? Yeah. It's, yeah, feeding, that's an easy one. It's the washing skills that are a little bit long,
Yeah.
and you
Yeah.
are going to get one.
Pressure bags.
Yeah, you are going to get a washing skill. So,
So on the pulse, you don't have to open twice. You just open once.
right, you
And then
open
you
once, you count, they're going to let you write that number down so you don't have to remember it. You count with the second one, you do your closing, wash your hands, document, wash your hands again.
Sounds easy enough.
Yeah, it's not hard. It really isn't. What, here's the thing. None of the skills are hard. They seem a little challenging to you because you're new, but none of them are hard.
That's a little hard, but not impossible.
No, not impossible. For me, foot care, that's probably the hardest because with my knee, I can't get up off the floor.
Oh, okay.
Not because the skill is hard. I mean, the skill is easy. I'm getting ready to retape these videos and I'm like, oh, I don't know. How am I going to do that? So that's going to be a challenge for me. But I don't think any of the skills are hard if you know the principles. If you know the principles, you could figure any skill out. Because if it's a washing skill, you automatically know. Don't add soap to the basin, check the water, let them check the water. Whatever you wash, you rinse. Whatever you rinse, you dry, right? Don't get your surface wet. If it's wet, address it,
Lay down a barrier.
Yeah, lay down a barrier. If you're going to put lotion on, warm it up first, wipe off the excess. I mean, you already know all this, right? It doesn't matter what I ask you to wash. Those rules never change, ever. So I don't think that any of the skills are hard. Some are a little bit more time consuming than others, and we require a whole lot more principles than others, right? That's just my take. Okay, so just to review our steps for range of motion. We want to lift the extremities from below with a flat palm. I did that. We want to provide 2 points of support near the joints. I did that. We want to move slowly and smoothly. Did I do that?
Yes.
Did I return all the way to the start position for every single one? Okay, remember flexion extension is up, down, abduction is side to side, and rotation is around. Okay, so those are our defining principles of this particular skill. Good. All right, so let's go on to catheter care. This is on page 114 of your skills book. Oh, all right, so this care plan tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Tells us to clean the catheter tubing and the perineal area only. So are we cleaning the buttocks? No, why?
It's not on the care plan.
There you go. Easy peasy answer, because we follow the care plan, the whole care plan, and nothing but the care plan. So I gave a presentation to instructors while I was there at the conference. And this is something that I do with some of my classes. I stopped doing it just because of time. But on the first day, I actually played Simon Says with my classes. Very first thing we did, play a game of Simon Says. And the reason that I played a game of Simon Says is because the game of Simon Says is CNA. Instead of Simon, it's the care plan, right? So remember the rules of Simon Says? When Simon says to do something, you have to do it.
Yeah.
You got to do it fast, right? If you do something that Simon didn't tell you to do, you're out. If you don't do something that Simon says to do, you're out, right? So you have to follow what Simon says, only what Simon says, and you have to do nothing but what Simon says.
Calling the care plan, the whole care plan, and nothing but the care.
There you go. So CNA is nothing more than a giant game of Simon Says. And it's a great way for me to get that point across to students. But first day is so jam-packed. I mean, I literally talked until 1 o'clock. So it's hard for me to kind of work that in because the schedule is so compressed. But keep that in mind. All right, so let's talk about catheters. On page 112, it goes over what we're about to talk about. So all your notes have been taken for you. I'm going to start on page 112, but let's review a normally functioning urinary system. Okay, we learned about this last week. Let's see how much you forgot over the weekend. We have 2 kidneys. How often do these things clock in to clean your blood?
24/7.
24/7. Do they ever stop? Okay, so they are constantly producing drops of urine. Those drops of urine fall down tubes called ureters, and they congregate in a bladder. What keeps the urine in the bladder? A valve, right? We learned that when you're incontinent, it's the valve that's broken. So you guys remember this? All right, this is still all in place when it comes to catheters. Nothing there has changed. What has changed is that we put a tube in there to hold that valve open. We're making this patient incontinent. Does that make sense? So the urine that's produced by the kidneys that falls down the ureters into the bladder is going to come out because we are holding that valve open with a tube. Now that means that those drops of urine are going to come right out into the wide world if we don't have something to collect those drops of urine, right? So the urine's just going to fall right out of that tube. It's got to go somewhere. Otherwise, the bed's going to get all wet. We're going to attach that tube, that catheter, to a drainage bag to collect the urine. So this drainage bag does the exact same thing as that bladder. Make sense? Mm-hmm. It is an external bladder. But all that catheter is doing, the whole thing that it's doing is holding that valve open. That is the whole job of the catheter. Hold that valve open so that urine doesn't congregate in the bladder. Make sense? So why would we need something like this? Why would this be important to us? Well, if we need to control the flow of urine, right? If we need some control over it, this is a good way to control the flow of urine. So during surgery, when we knock you out, we knock everything out, including that valve. So chances are you're going to pee on our sterile field because your valve is asleep. Make sense? So during surgery, we often use a catheter. We can also use the catheter if somebody has something wrong with the nerves that control that valve and it's permanently closed. It doesn't open up on its own anymore. So we can use a catheter to hold that valve open. Remember, that's the whole purpose of the catheter, is to hold the valve open. If the valve is open on its own, if it's just kind of floppy, like incontinent, and it's open on its own, we don't need a catheter for that. The valve's open. Don't need anything there to hold that valve open, do we? We would only use a catheter if we need to control the flow of urine. Okay. So if I've got a patient with a huge bed sore on their backside and they're incontinent, I might consider using a catheter because I don't want the urine, which remember was acidic, to come into contact with that wound, right? So that might be a good use of a catheter. But if I have an incontinent patient with no wounds, no problems, I don't need a catheter because urine's coming out all by itself. We're just going to get that patient cleaned up every, how often? 2 hours around the clock. So you guys starting to see that catheters aren't used for convenience. They're used when we need to control the flow of urine. Now, this is kind of important because way back in the 70s, man, if you went into the hospital for anything, we gave you an IV and a catheter. It was just like, we'd hand them out like M&Ms, right? Everybody got an IV and a catheter. And we started to realize that that probably wasn't the best course of action. You know, we didn't want you up walking around. We also used side rails back then, right? We didn't want you up walking around, roaming the hallways. So we found ways to kind of keep you in bed. But that wasn't healthy for the patients. In fact, catheters are the number one reason. Remember those hospital or healthcare acquired infections we talked about, right? Remember 1 out of every 25 patients. Okay, this is the number one source of infection in healthcare settings, catheters. They kill about 2,500 people a year. Yeah, this is kind of a big deal. So once we realized that, we started reducing the use of catheters to just those that absolutely need a catheter. So how does that happen? How does something this benign cause people to die? How does that happen? Well, remember that we aren't putting catheters in healthy people. We're putting in catheters in patients that have something else wrong with them. So their immune system already busy, clocking in overtime. Now, when we introduce a new pathogen into a patient whose immune system is already busy, that can be disastrous because they may not have the resources to fight that off. Does that make sense? Okay, so if you remember in here, in this urethra, right, the tube that goes from the bladder to the outside world, it's only about as long as your pinky. In this area, we have white blood cells. Now, what do those white blood cells do? Okay, so any invaders, their job is to get rid of them. Good? Okay. Well, when we put a tube up there, the invaders aren't on the outside of the tube. Where are those invaders? On the inside of the tube. So are our white blood cells going to have any effect on those invaders? This is a Trojan horse. Anybody remember what a Trojan horse is? Right? This is very, very dangerous because what happens here is if we get any bacteria in that bag at all, any, and it only takes one, right? Because bacteria don't need little boy bacteria and little girl bacteria to have baby bacteria. It doesn't work like that. Bacteria need the right conditions: warm, dark, moist, but they also need certain enzymes and proteins to help with procreation. Well, those enzymes and proteins happen to be in large abundance in urine. So you get one bacteria in that bag, just one is all it takes. It eats, drinks, and is merry and zips itself in half. And now I've got 2. Now those 2 eat and drink and zip themselves in half. And now I have 4. And then 8, 16, 32, 64, 128, 256, 528, 1064. And it goes on and on and on. And it doesn't take a whole lot of time for this to happen. So as those things are happening in the bag, the bacteria are kind of getting a little crowded. So they start moving out into the suburbs and they start climbing the tubing. And now they're getting fresh urine. And oh, that tastes much better. So they really start ramping up production. And then they get into the catheter itself, which is now blocking out light. So now we've got all of the conditions we need for procreation. So now they're really ramping up production, and they climb and they climb and they climb, and they haven't encountered any bodyguards because they're inside the system. They get all the way up to the top to the holes, and they jump out now into the bladder. Now, this is very fast and overwhelming because it's not just one or two bacteria that are climbing out. It is trillions of bacteria that quick. So it'd be like all of Canada invading Spring Hill in like 15 minutes. I mean, it's overwhelming, right? Our roads are bad enough. Don't bring any more in. But it would be overwhelming. Now, the body just isn't able to fight off this overwhelming invasion with limited resources. So when it comes to catheters, our biggest consideration is not letting any bacteria in the system at all, not even one. So this process has to be super, super clean. Does that make sense? Good. One bacteria is all it takes to cause this. Just one. And remember, there's nothing in that system that's going to stop this from happening. Nothing. That's scary. Now, after the bladder gets overrun, there are a couple exit points, right? When we need more space to roam, there's a couple of exit points. Anybody know what these tubes are? The ureters, where do they head? And the kidneys has a direct line to the bloodstream. Do you think that might be dangerous at all? Yeah. Do you see why catheters kill 2,500 people a year? Okay. All right, so let me explain to you what catheters are. So a catheter is nothing more than a hollow tube. That's all it is. It is a straw. I mean, it's a flexible straw, but it's a straw. It's a hollow tube. And we used to use straws, believe it or not, back in the 1800s. We used glass straws as catheters. They were very thin glass tubes that were used as catheters. But, you know, glass isn't all that flexible. So when you had a catheter, you had to stay pretty still. And that's just not feasible, right? We also realized that putting a hollow straw in a tube could cause some comfort issues. So along the way, they thought, okay, well, what if we just kind of closed in the top part so it's not hollow? It might make it a little easier to put in, right? So we closed in the top part, put some holes in there on the sides rather than the top. That was a good improvement. And then we said, well, why don't we make it a little more flexible so people can move around? And that was an improvement. And this is what we have now. We have a flexible straw that the top is closed in and the holes are on the side instead of the top. That's all a catheter is. It's a flexible straw. Now, the problem is that a straw by itself isn't going to help anything, because now instead of the urine being held in the bladder, it's going to come out this end everywhere. So we have to connect it to something to hold that urine as it comes out. And that's a drainage bag. Now, there's all kinds of drainage bags. Lots and lots of different types of drainage bags. There's big ones that hang on the bed. There's small ones that attach to the inside of the thigh. There's all kinds of drainage bags. We don't care. It's an external bladder. Don't care what it looks like. But the point is the two pieces go together. Good? Questions? But this is a flexible straw. If you put this in, It's not going to stay in by itself. It's just going to kind of slither its way out like spaghetti. I mean, it's flexible. So what we have to do is have a way of keeping this flexible straw inside the bladder once we get it there, because otherwise it's just going to slither right out. And that's what this is. This is a balloon that's inflated once it gets into the bladder. Not right away. You can't put this through a tube this big. So we get this in place and then inflate that balloon, and it acts as a doorstop. I'll show you that in a minute. There's 3 points of contact here that we have to be concerned about, though. 3 places that bacteria can get into the system. The first is here, where we put the catheter in. Now, this is the nurse's problem. CNAs don't put catheters in. You don't take them out. You can be trained to do that if your job requires it. But as a general rule, CNAs don't do that task, right? So when the nurse is putting a catheter in, she's got to make sure that this stays sterile, that she's not touching it with gloves that have touched other things. We need this sterile, right? We don't want to insert bacteria into the system. But the other 2 are ones that CNAs do work with. So we need to be aware of this and careful of it. So the catheter itself and the bag are going to connect together. You see that right here. Oops. The catheter itself and the bag connect together. If we allow bacteria into this area, now that bacteria doesn't have far to go to get inside the body. That makes sense? So when a catheter and a bag are hooked together, this needs to be a very, very, very clean process. This, again, is not something that CNAs do routinely. You must be trained to do it. Okay, good. But the one thing CNAs do routinely is empty the bag. So the 3rd point of entry is the port. So when it comes to emptying the bag, we don't want any bacteria in this bag. So when we empty the bag with the port, we don't want that port to touch anything. It can't touch your gloves. It can't touch the cup, the bed, the floor, the chucks, the bag, nothing. We want to make sure that this port stays pristine. So it lives in this little house right here, this little pouch. When we go to empty the bag, we remove it from its house. We slide the valve to the side to open it. We empty. Once it's empty, we slide the valve to close it because you don't want any bacteria to have a doorway in. And then we put it back in its little house without letting it touch anything. Good? Questions? So just to recap, nurse takes care of this end. CNAs can be trained to do this, but CNAs do empty the bag. This is our main point of origin for pathogens. So we've got to be super, super careful of what we're doing. Good? Questions? Okay. Let's go back up here. All right. So when a catheter is inserted, that balloon is not inflated. So that catheter is going to be inserted through the urethra, and it's small, like this. It's small. Once we get that catheter in place, and we know we're in place because urine starts pouring through those holes and we see urine come out, we know we're in the bladder. Then we inflate this little balloon to keep it inside the bladder, but we can't feel this because it's inside the bladder. Bladder is a hollow organ. It's like eating one potato chip. You can't feel that potato chip in your stomach, right? Because your stomach is hollow. That's like this. When we inflate this balloon, you can't feel it. It's hollow. What you feel is this tubing, because we want this to be a snug fit. We're holding the valve open. If it's not a snug fit and we're holding that valve open, urine is just going to come right out of the bladder beside the tubing and make its way out into the world. And now we got a wet patient. So this has to be a snug fit. Does that make sense? Not overly comfortable. I mean, it's not painful, but not overly comfortable either, right? We have a snug fitting tube where a tube normally is not. It's like those of you who have pierced ears, if you wear earrings that are bigger than what you're used to, you know how it irritates you?
Yeah.
You know, and you're like, okay, I got to take these out because they're really they're getting under my skin a bit. That's the same type of feeling here. Now, if your patient is saying, ow, 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 it hurts, it hurts, it hurts, that is not uncomfortable. That's pain. What do we have to do when our patient reports pain? Yeah, tell the nurse. Absolutely. Like now. Anybody ever have a Charlie horse in your leg? How bad do they hurt? Like on a scale of 1 to 10, 43, right? They're pretty bad. And they can get like all consuming. Well, very small percentage of the population, very, very small. When we put a catheter in, their bladder says, oh no, you don't belong. And it spasms, which is a Charlie horse of the bladder, to try to push that offending item out. A bladder spasms are very, very painful. And you don't want to wait. You don't want to go to lunch and then let the nurse know at the end of the shift. When the patient says, ow, it hurts, believe them. Go get the nurse right away. Now, I have a medication that I can give patients that are having bladder spasms. And it's great because it puts a bladder to sleep. Bladder doesn't care that there's a tube there anymore. That's awesome. No more discomfort for my patient. The problem is that medications often have side effects and risks. One of the risks for this medication is the bladder may never wake back up. That's a risk. So as a nurse, I have to evaluate, is this catheter necessary? Can the urine come out any other way? If the urine can come out any other way, then I'm probably going to take the catheter out and we're going to go with that. Okay. But that's an assessment that has to be made at the nurse and doctor level. Good. Questions? You guys kind of understand how this works? So as a CNA, you do not put catheters in or take them out without additional training, but it may be something that you are trained to do depending on the setting that you're working in and the needs of the patient. Okay. But when a catheter goes in, and something the nurse does, this is inserted up the urethra, and see how it's more narrow now, and it wouldn't be all puffy here. This is just because the balloon was inflated. When we put this in, we advance it until we get urine out. And once I know it's in place, I'm going to push up just a little bit further to make sure that that bulb isn't in the urethra, because that would hurt. And then I put a syringe and water, and we blow that little balloon up, and that's now a doorstop. It just keeps the catheter in place. Now, the problem is that it makes this tip kind of stick up. There's only one thing that's ever hit the top of your bladder, and that's pee. That's the only thing that has ever hit the top of your bladder. So if we keep the bladder small, because all the urine is going out of the tube, right? There's nothing in the bladder. It's keeping it small. That means this tip is going to hit the top of the bladder. And what's the only thing that's ever hit the top of the bladder? Pee. So your patient's going to be like, excuse me, I have to pee. Yeah, I know. Your body thinks it has to pee. You actually don't. The urine is coming out of the tube, but the body is going to interpret that as there must be pee here. Bladder's not a really bright organ. It only has two sensors, pee and pain. That's it. Those are the only two words it has to work with. So it's very, it doesn't have a lot of choices. When it feels something, it has to send one of those two signals, pee and pain. That's it. This is why when you have a UTI, you feel like you have to pee all the time and you can't go. Yeah, that's because the bladder only has two words, pee and pain. And when you have a UTI, it hits both buttons, pee and pain, right? Because it knows something's going on. Make sense? Okay. So that's why the patient feels like they have to pee with a catheter. They don't have to do anything. The urine is coming out. This sensation actually goes away after about 10 to 12 hours. So if your patient can kind of get involved in something, watch a movie, read a book, take a nap, kind of distract themselves a little bit, this sensation does go away over time. Pain is different. What do we do with pain? Report it to the nurse. But I have to pee. Yeah, it's kind of normal. Good. Questions? Okay. So this is an indwelling catheter. It has a bulb on it to keep it in place. That means it can stay in a bladder for up to 30 days before it has to be switched out. But sometimes we don't need a catheter to stay in place. Maybe we just need a quick urine sample, or we just need to empty the bladder before a procedure and our patient's a little shy and can't go. Okay? So that we would use this type of catheter. Notice there's no bulb on the end. This is a straight cap, but it has a lot of names. You'll hear it called an intermittent cap, which means it doesn't stay. This is indwelling, it stays. Intermittent does not. It's called a straight cap because no bulb, but it's also called a Red Robinson. I'm assuming because the guy that invented its name was Robinson. I don't know. I don't know. The red part I get, but the rest of it, not sure. This is an indwelling catheter, also called a Foley catheter. And again, I'm assuming the guy that invented it was named Foley, right? But I don't know. So Red Robinson, Foley. Good. Questions? Okay. Now, unfortunately, sometimes patients find this is a bit irritating. And some of your patients that don't know any better, some of them that do, will pull on the catheter because it's irritating. And sometimes they'll succeed and pull it right out. Now, when a patient pulls a catheter out, we have a bubble this big going through a tube this big, so we're going to get tissue tearing. It's going to happen. No way around it. That means you'll see a little blood, a little urine. Your patient is not going to die. Do not freak out. They will take their cues from you. If you go, oh my God, what did you do? Your patient's going to freak out on you. Okay. Be calm. I want you to take the whole system, the bag, the catheter, the whole system, put it in an empty trash bag. There's always empty trash bags under, in a trash can under the main bag that's out. Get an empty trash bag, put this whole thing in the trash bag and put it in the bathroom for the nurse to look at. Do not throw it away. It's just going in a bag for storage because we don't want to put this on the bare floor, right? We're not throwing it away. We're putting it in a bag until the nurse can look at it. And there's a very important reason for that. As the nurse, if a catheter gets pulled out, I have to look at this part of the catheter. And I have to make sure that the whole thing is still there. Because if the catheter gets pulled out and it looks like this, I know the whole thing is still there. There it is. Bubble is still there. But if I look at the catheter and it looks like this, where did my bubble go? More importantly, where is it now? Could be. Now, this a nurse can deal with. This requires surgery. Because we can't leave that in there. If you leave that in there, the body will interpret it as a foreign object and start to attack it. And now we've got an immune response. That's not good. So the only way for me to know what sort of a situation we're dealing with is to be able to look at the bubble. So you need to take this whole thing, put it in a bag in the bathroom, go find a nurse and say, hey, the patient's catheter is out. It's in a bag in the bathroom if you want to go take a peek. Now, the nurse is going to figure out what to do from that point. Now, ideally, we'd like to put another catheter in, but if my patient's just going to pull it out, what's the point? Right? So I got to figure that part out. But I have to look at, is there any other way that the urine can make its way out of the body? If no, if the patient's got a monster tumor there, I may not have a choice. We may have to have a catheter, but that's something that we're going to have to look at. Does that make sense? Okay. It's important that you do this quickly because anytime there's injury, remember there's injury, right? This bubble went through a tube this big. Anytime there's injury, there's swelling. Probably not a place that we want swelling. And if I don't get a catheter placed before the swelling starts, we're not getting a catheter placed. And if the patient doesn't have any other way for the urine to come out, that's a bad day. Does that make sense? So again, this is a let the nurse know right away situation, not go on break, take care of 5 other patients and tell the nurse when you get around to it. Okay, does that make sense? Good. Okay. But unfortunately, CNAs pull out way more catheters than patients do. Yeah, we're bad at this. We are really bad at it. Patients will pull them out, but CNA is way worse. When we're turning a patient over in bed, if we aren't aware that there's a catheter and we lean against the bed and trap that catheter between our leg and the bed, when we turn that patient, that catheter is coming right out. If the tubing is coiled near the floor and your feet get caught in it, you'll pull that catheter right out. When you're transferring a patient out of bed and into the wheelchair and you don't pay attention to where the bag is, you'll pull it right out. And when you ambulate a patient, when you get them up out of the chair and start to walk, if you leave the bag on the chair, you're going to pull the catheter right out. We pull out way more catheters than patients do. So when it comes to catheter safety, being aware a catheter exists is number 1 consideration. So you may have a written test question that says you are assigned to ambulate a resident in that has a catheter. What is an essential step for this patient? A, apply a gait belt. B, ask if they're dizzy. C, have a second staff member help you. Or D, make sure the drainage bag goes with the patient. Now, I want to point something out for this question. It says, what is an essential step for this patient? That one word, this, counts because gait belts are important. But what is an important consideration for this patient? The drainage bag. That makes sense? Okay, good. Drainage bags always need to be lower than the patient's hips because recycled urine, ew. You raise that bag up, whatever urine is in that tubing is going right back into that patient. And I don't know about you, but for me, urine really should be a one-way trip only, right? I don't want to recycle urine. That's just kind of gross. All right. So these are our safety steps for catheter. The bag needs to be below the hips at all times. That way we're not recycling urine. The tubing should be coiled on the bed, not near the floor. That keeps your feet from getting tangled up in it. The bag needs to be hung from a non-moving part of the bed. We want to look for the catheter before we move patients, and we want to report any patients that are tugging on their catheters. These are all designed to make catheters safe for the patients and prevent that injury from occurring. Can you imagine for a second what it would feel like to pee through tissue that is torn? What's that going to feel like for the patient? Oh yeah, it's going to burn and sting and feel like they're razor blades coming out. So we want to try to avoid this at all costs. Okay. Now, this is probably the most common mistake I see with catheters. And, I'll go into a hospital and there's, staff members that are walking patients up and down the hallway, and they have the bag hanging on the IV pole. Recycled urine all day long. Don't do that. Never lift that bag above the patient's hips. And then tubing coiled on the floor is probably the second most common mistake I see with catheters. Always make sure that tubing is on the bed, not coiled near the floor. So we don't want the bag to touch the floor. Remember, the floors probably have pathogens on them. So we want that bag high enough that it's not touching the floor or dragging on the floor. If for some reason the bed is super low and the bag is touching the floor, get something to put under that bag, a chucks, a basin, something, so that bag isn't resting directly on the floor. Okay. That happens a lot with low, super low beds for patients that climb out of bed a lot. So again, ways that catheters are pulled out: turning a patient over in bed, that's common. Transferring a patient to a chair or wheelchair, when we ambulate patients, when our feet get tangled in the tubing near the floor, confuse patients. And sometimes your patients will intentionally pull it out of spite, which the only person they're hurting is them, but if it makes them feel better. Now, interestingly enough, when you're walking a patient and the catheter comes out, a lot of times they won't know it right away. It just feels like and the catheter comes out, because it's pressure. Mm-hmm. The pain doesn't start until a few seconds later. Yeah, when they start to, when everything is starting to react to that injury. So if your patient is walking and the catheter comes out and they don't really react to it right away, don't assume that they're okay, because that pain reaction just hasn't really set in yet. So sometimes we have to document. Now, remember that most documentation for CNAs is numbers. Remember I talked to you about that? But some places will have you document in words. If you have to document in words, try to limit your use of I. Remember, this job is not about you, it's about the patient. So we always limit our use of I in documentation. A better way to document this, after you put the bag, the catheter and the tubing in the bag: catheter found laying in patient's bed, catheter and balloon intact. Notice there's no I there, right? And we're telling what was found. So brief, accurate, complete is what we're looking for there, and limit your use of I. All right, so here is our care plan one more time. Provide catheter care with soap and water to a female resident. So I want to stop there for a second. Males can have catheters, sure, absolutely. We're not demonstrating that on the test because, again, the way you wipe with a female is way more important. So it's the same catheter for males and females. Exact same. There is no male version of this. There's no female version. It's the same. Female urethras are about as long as, so it only has to go in about that far, right? Male genitalia, it has to go through the entire penile tissue. So we're going to have to advance it in a little bit further. It is the same tube, people. Doesn't matter whether it goes in this far or this far, it is the same urethra. So males tend to react a little bit more negatively to catheters, and they generally will pull them out a little bit more often.
I've heard of people, either like men being confused or the dimensionless, that pulling it out so much that over time their penis flowers.
So that to me tells me that they did not get adequate nursing care to try to come up with a different solution. So yeah, I mean, when you're pulling a balloon out of a tube, right, it's going to cause that urethra to scar tissue is going to build up over time. It can cause some long-term effects.
Just don't know. I've heard the term, I don't know what it means by like they flower.
So what that means is the opening of the urethra where it comes out,
Yeah.
it looks like kind of like an open flower. Okay, so like the opening of the urethra is what we call dilated, very dilated. But it should never get to that point. The nursing team should come up with a different strategy, because clearly this one is not working for the patient. That's where that assessment and planning comes in. All right, so I'm going to pass all of this around. Oh, one more thing I forgot to tell you. Catheters and bags are two separate pieces. Do you guys remember how long I said a catheter can stay in for? 30 days. These bags have to be changed out every week. So if we have a bag that has to be changed out every week and a catheter that lasts 30 days, it tells you they've got to be two different pieces. Right? So I'm going to pass all of this around. You can see a catheter that has a hole in it that has burst. I have a couple of them here. You can see the Red Robinson, and you can see one with a balloon intact. Now, those balloons can be different sizes depending on the needs of the patient. They can be different sizes. The catheters themselves can be different sizes. There's very, very, very tiny catheters for babies. There's very, very large catheters for patients that have larger urethras. So there's different sizes, and that's the nurse's responsibility to figure that part out. But this is pretty standard. These are 16 French. That's pretty standard. One size fits most, not all.
I wish we could get a catheter in a male's pinhole. How you gonna get it in?
It's just there's just a technique that you use.
It doesn't hurt.
No more,
It's tiny.
no more than it's the same size as your urethra.
Really?
No. This is a different, so when you look at the female anatomy, right? So the vagina is lower, and yes, we do push babies out of that, right? So just above the vagina is the urethra. So the urethra is a different opening. It leads to the bladder, not to the uterus. Your urethra is the same size as a male's. The only difference is the male is longer. Yep. It's the same. Yeah, it's the exact same process, female or male. It's the same process to insert a catheter. The difference is males only have one hole. We have two. Yeah, it's like I said, it's not comfortable, but it's not painful or shouldn't be painful.
I'm sorry, I didn't hear what you said. We have two what?
Two holes.
Oh.
You have a urethra and a vagina. They're lead to two different places, right? The urethra leads to the bladder. The vagina leads to the uterus. Two different places. So here, this illustrates it a little bit better, right? So here's the vagina. This is the one that most of us are used to, right? The hole we know about. But just above that, way up here at the very, very top of your perineal area is your urethra. And it looks just like a male urethra. It's a hole, just like the male urethra. And that is where the catheter is going to go. So when we're cleaning the catheter, we want to hold it right there at that urethral opening. We want to hold it while we're cleaning. Because if you don't hold it, if you just grab the tubing and clean going down the tubing, you're going to pull that catheter. We don't want to pull it. So we want to hold it steady while we're wiping away. Okay. So we're going to use the same leaves method that we used with PeriCare. We're going to hold the washcloth around the tubing, hold the tubing and wipe away from the urethra. Remember, we always move away from the urethra. Then we fold that over. We're going to wipe again, fold that over, wipe again, fold that over, wipe again, fold that over. So 4. Whatever we wash, we rinse. So we'll do the exact same thing. And then whatever we rinse, we dry. And then we're going to do PeriCare. We know how to do PeriCare. We learned that last week. So once down the middle, outside, outside, skin fold, skin fold. Whatever we wash, we, whatever we rinse, we dry. So it tells us to wash the tubing and perineal area only, so we don't have to wash the buttocks here. We are going to put our chucks under the patient while we clean, just to keep the bed dry. We're going to take it out when we're done because we don't need it. We're going to do the opening. We're going to wear gloves. We're going to use a barrier. We're going to use a privacy blanket. Linen rules apply. Scoot and roll to put the chucks in place. Washing rules, basin cleaning, and the closing. A lot of principles here. Okay. So here are our steps that we have to remember. We're going to protect the sheet with the chucks. That keeps that sheet dry. We want to use the leaves method, a new leaf per stroke. We're always going to clean from front to back. We're going to clean down the middle, the outer labia each side, and the skin fold each side. We never move back up. You guys remember that? We're going to hold the catheter at the meatus or opening as we're cleaning. We're going to clean the catheter tubing 3 to 4 inches out, and then we'll remove the chucks at the end. Okay. Oh, Miss Shalee, my CNA exam is today. Well, good vibes out to you. Good vibes. Looks like you're reviewing before your test, so we'll keep our fingers crossed for you. All right, so let me go ahead and show you this video. I am going to show you the video because it has good close-ups of this particular skill. Okay. My name is Patti. I'm your CNA Training. How are you? Good. I need to be catheter here. Is that okay? I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Okay, Ms. Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, the chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves.
Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature, make sure it's okay? It's good? Good. I'll place the washcloth in there to stay warm. I'm gonna cover you with a privacy blanket. This is gonna help protect your privacy and keep you warm while we do this skill. And I'm gonna pull your sheet down to about your knees. Okay, Ms. Jones, I'm gonna place this pad underneath you. This is gonna help keep your bed dry while we do this skill. First, I'll roll it toward me. Place it on the bed. And then I'll put my gloves on. All right, Ms. Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. Going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the checks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Ms. Jones, can you scoot to the middle of the bed, please? Thank you. Ms. Jones, can you scoot for me? Thank you, and roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the back. Come on back, Ms. Jones. And scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or strokes on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out. And apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to fold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whatever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do caregiving. We'll take a washcloth out of the basin, bring it out really well. And we're going to soak 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf. Always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom. Fold that leaf over. Clean down the other side of the labia, top to bottom. Fold that leaf over. I'm going to clean the skin fold between the groin and the leg. Fold that leaf over and clean the other skin fold between the groin and the leg. And then set that washcloth aside. I'm gonna take the final washcloth and we're gonna well. And we're gonna rinse all of those areas the same way that we washed them. So I'll pull that catheter out of the way and spread the labia open, clean down the center, top to bottom. Pull that leaf over, clean down one side of the labia. Pull that leaf over, rinse down the other side of the labia. Pull that leaf over. We're going to rinse the skin fold. Pull that leaf over and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Miss Jen's going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not pink. Miss Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer and on the way we'll pick up the soap. We'll open the drawer with paper towel. Return the basin with storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot for me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the back. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table. And we're going to throw this away. And then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call light. If you need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like magazine? I'm just gonna open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections that need to be made, and then tell the evaluator my skill is done.
Hey. Now it's getting cold. Any questions on that one? Any questions? No? It really isn't. There's a lot of steps to it, but they should all be steps that you're familiar with, right? At this point. Good. All right, let's move on to page 117. And page 117 is about how to empty the drainage bag. This care plan at the top of the page says to empty the resident's urinary drainage bag into a graduate container and measure and record urinary output. Remember that in medicine, we use mLs or cc's, not ounces, on the output form. So let me show you what a graduate container is. This is a triangular. It's in the shape of a triangle. Come over here where you guys can see. So this is a triangular graduate, which means it has graduated markings on it for measuring container. That's the term of this. It's triangular graduate container. This is not a urine cup. It's important to make that distinction. A urine cup is a very small 4-ounce round cup with a lid. That's used for urine samples. This is a triangular graduate container. Different. So I want you to be aware that these are two different things. Now, this container has markings on it. And these markings on one side are ounces, but we're not going to use that side. We're going to use the side that says cc's or mLs. Remember, cc's and mLs are the same thing. So when we empty the bag into this container, remember that port can't touch anything, right? Well, we want to put this, can we put this directly on the floor?
No.
What do we need to use?
Barrier.
A barrier. So we're going to put a barrier on the floor. We're going to put this on the barrier. We're going to empty the urine into this, not letting that port touch anything. Once we empty the urine into this cup and we look at it, it's going to land somewhere. We have to measure this on a barrier, on a flat surface, at eye level. If you miss just one of those things, you don't get credit for any of it. So it has to be on a barrier, on a flat surface, and at eye level. So when you get down eye level to this and you see where that line is that the urine is closest to, that is your mark. So if the line is here, right here, this is all done in 50s. You can see 150, 200, 250, 300, 350, 400, 450. If my line is right there, if that's where my urine ends, right there, halfway between 400 and 450, what would that mark be? 425. Now, if it was just a little tiny bit above that 425, I would still call it 425 because you're going to round to the nearest line. Doesn't matter whether it's up or down, whatever line is nearest. Okay, so I'll pass this around so you can see it. So we're going to empty the bag into this container. We're not going to let that port touch anything. Once we've measured it on a barrier, on a flat surface at eye level, then we're going to dump the contents of the cup. So where would urine normally go? That's where we're going to put it. So we'll rinse the cup and we'll dump the rinsed water in the toilet as well. Then we're going to dry it and store it the same way we dry and store everything else. Good? All right. So when it comes to catheters, because we're emptying a catheter bag, so that's going to be attached to a catheter, there's several different types of bags that we can attach to catheters. There's the bedside bag, which is what I passed around earlier. It's big. It's designed to contain urine over an entire 12-hour shift. It's going to hold a lot of urine. It's usually only going to be emptied once per shift, usually at the end of the shift. Good? But if a patient is not in bed, if they're out and about, if they're interacting in the community, nobody wants to carry a suitcase of urine around with them. That's just a little embarrassing. So when you have patients that are in the community, they don't normally use those types of bags, even though they still have catheters. They're going to use something more discreet. And you'll see that at the top of page 116. This is a leg bag. It actually attaches to the inside of the thigh or the calf with elastic bands or Velcro bands to hold it in place. And it operates just like any other bag that collects urine. It's just a little smaller. So your patient can go into a public toilet and empty the bag into the toilet themselves if they want. If you have to empty the bag, that could be that bag port is usually a twist. So you would twist to open, let the urine out, twist to close. Good. Questions? So there's different types of bags for different purposes. How do we know which bag we're using? Care plan, just like everything else. We don't make decisions, we just follow the plan. There's also a different type of catheter I want to talk to you guys about. So we talked about an indwelling Foley that has the bubble to keep it in place. We talked about a Red Robinson or intermittent that's just put in long enough to empty the bladder and then taken out. But there's also a different type of catheter that we use for men called a Texas cath or external cath. And this looks like a condom. It has a little port on the end of it. You can see it there on page 116, halfway down the first column. And this goes on similar to a condom. It's sticky on the inside, usually stays on for 3 days. It goes along the outside of the shaft and it directs the urine out that port into the bag. If your patient has an external catheter, when it gets removed after 3 days, we've got to pay super close attention to the skin because that skin has been in contact with urine for 3 days. So the very tip of the where the port is. So you want to do really good skin care there. Okay, good. So pay attention to the skin, report any abnormalities that you see.
So you don't take it off if for 3 days, you don't take it off in between each day?
No, it goes on, it stays on for 3 days, and then we take it off, clean, dry, very good. Look for any skin issues.
The voice the entire time.
Yeah, if the adhesive is good quality adhesive, it shouldn't let any liquid down beyond the port area. It's the port area that we get a little concerned about. And again, none of this is a perfect solution, right? None of it is a perfect solution is your patient's totally continent and goes to the bathroom by themselves. That's what we're hoping for. And remember that we can help patients redevelop the ability to be continent by doing bowel and bladder retraining, which is taking them to the bathroom every 2 hours around the clock, right? So that's ideal. That's what we want to do. That's what we want to get our patients to, but not everybody will achieve that goal. So we do have several different types of catheters. Now for females, we don't have an external catheter like this. Females have a new thing. You'll only see this when they're in bed though. It's called a pure wick. And it looks like think of a tampon sideways. Okay. Yeah, long. And it has like a plastic sheath that it sits in, and it goes in between the labia. And it collects it uses just a little bit of very light suction to collect the urine and pull it away from the body and deposit it in the can. But females can't use this if they're up walking around. This is only in bed. So females don't have an external application that can be used anywhere. Men do. Okay. Good. Any questions on that? All right. So remember that the bag is going to be hanging on the bed. We want it on a non-moving part of the bed. We don't want it touching the floor, and we don't want the tubing coiled near the floor where feet can get tangled in it. So part of emptying the bag is going to be to look at making sure that it's in the right position, that it's not touching the floor. We're going to remove this port from its little house. We're going to fold it down and make sure it doesn't touch anything. We're going to use this T-valve, open it, empty the bag, close it, and then put it back up into its little house. Now, years ago, we actually used to clean this port with alcohol before we put it back. And that was designed to help prevent any pathogens that might have gotten on that port from entering the system. The problem is that alcohol is very drying. And what we found over time was it was causing little micro cracks to form that bacteria could hide in. So they found out that that's not the best option. The best option is just to empty it, don't touch anything, and put it back in its house. Make sure it's closed. Okay. So we don't clean with alcohol any longer. When we measure, we want to make sure it's on a barrier, it's on a flat surface, and we're measuring at eye level. So that means we actually have to get down and look at it. So you can't hold it up to get it to eye level. It's got to be on a flat surface. And then you've got to get way down to look. Don't do this. That's not eye level. Okay. We're going to round to the nearest line. We're going to document this. This documentation form is a little bit tricky. You can see it on page 117. It's also on page 120 if you want to, or 121 if you want a bigger version of it. But this is a little bit tricky because it's got two areas. You've got intake and output on the same form. What is urine? Is it intake or output? Well, I hope so. I wouldn't want urine as intake. So make sure that you're putting it in the right box. If you put the information up here, you will not get credit for documentation. You guys understand that? So we're going to put the time. You should use military time, but you don't have to. If you're not using military time, you have to use AM or PM. You're going to put the type of output, in this case, urine. You're going to put the amount of output, how many cc's you measured, and your initials you'll sign at the bottom. So here's our important points. We want to protect the floor with the chucks. We want to keep the bag lower than the hips. Inspect the tubing. Make sure it's not tight or near the floor. Don't let the port touch anything. Close the valve and return this to the storage flap. Wrap the chucks around the container to carry. Measure it on a barrier, on a flat surface, at eye level, and document. Those are your important points for this particular skill. Remember, all of our normal rules apply. The opening still applies. Glove rules still apply. The closing still applies. Good?
I have a question.
Mhm.
So between, so say, we're doing the scale, I'm looking at the amount of urine in the graduated container and it's like 350 cc's. So I have to hold that in my head, clean up everything, wash my hands, and then document it.
Right. And then wash your hands again.
And then wash your hands again. And when you document, is it the time you were documenting right then, or is it the time, because it's gonna be a couple minutes of like
Yeah.
cleanup?
It's not that specific.
Okay.
It's, within a 15-minute window is fine.
Okay, perfect.
Yeah, it's not, you don't have to say like 10:42.
Gotcha.
You can say 10:40 or 10:45, whatever you want to use,
Yeah.
but it's within that time frame. Okay. Good question. Doesn't have to be that specific. All right, I'm going to show you this video as well for two reasons. One, it has really good close-ups. The second is I'm not bending. I just cannot do that.
Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great, I need to empty your urinary drainage bag, is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not pink, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and strip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the tucks over the graduate container for safe and secure transport to the patient's cabinet. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters, or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, paper towel to dry the inside. We'll discard this and then one for the door. We're going to place the graduate container in the bottom drawer and close the drawer with the paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right. Any questions on that? Questions? Okay, here's your review sheet for today. Review sheet 4 and 6. 4 and 6, okay. I can take care of that. Okay. Does anybody else need any review sheets?
Here's 4. That's 4. Let me see if I can find 6. If not, I can print it. Thank you. You're welcome. Okay, and there's 6. I can have 1 6.
Okay, one more review sheet that I'm going to give you. And this one. Do you remember I told you on the first day of class? We were going to learn all of those banners, all of those principles. And you have learned all of those principles. And this review sheet is designed to show you that you know all of those principles. And remember, that makes up the entire skills exam. So this is the principal review, and it goes over every single principle on that back wall. If you can go through this and answer most of these, you've also got it in your skills book on page 19. They list them all there for you. But if you can go through and answer these, you are ready for the test. Okay.
Does anybody have any questions for me? Questions?
Did you say that there's a ebook of this, like the textbook online, or?
I don't know if they have an ebook online. I'm not sure. They might.
Okay.
You can look on Amazon. They might have like a Kindle version.
For the yellow one?
Yeah.
At the bottom, it says something about Audible
Yeah,
online.
yeah.
I have it.
You have it?
Yeah, it's on there. The yellow one.
Thank you.
You're welcome.
Oh, cause you said on your website, there's the free ebook. Is
Right.
that
That
not the textbook? It's
No.
something else?
the free ebook is on test taking strategies for the written exam.
Gotcha, okay.
Yeah.
Can you help me to download that? Cause I had a hard time downloading.
Okay. Did you sign up for it? You have to put your email address in and then it gets emailed to you. And in the email, you just click on the book and it downloads it.
I put my email in when I first, and you sent me the first video. So would I have to go back? What was the name of it?
It is Test Coaching eBook. So you can pull up your email and see if you got anything from For Your CNA on the
I do
ebook.
have, oh, okay, I do have something.
Yes, Erica, I have all of the review sheets for you when you come in on Wednesday. So when you guys come in on Wednesday, you need to bring your yellow books back. You'll be turning them in on Wednesday. Don't forget to bring them back. And then the rest of the class today is practice. You are now officially done with the skills. Great job, guys. All right, so you two people, I'm gonna go ahead and sign off because we're opening this up for practice. Tune in on tomorrow for our live practice test game show. It's gonna be tons of fun at 11 a.m. tomorrow. And Wednesday, we'll be wrapping up this class with graduation. Yay! I will be taking a class photo if that matters to anybody. I'll be putting it on Facebook. And I don't tag anybody. You have to go to my Facebook page to share it if you want to share it to your timeline. And Thursday, of course, is my live weekly question and answer session. So feel free to tune into that as well. So until next time, guys, happy caregiving. Bye.
Sorry.